Started. Yay. Okay. Basically, these are accessory structures. The liver and the pancreas are the structures. The gallbladder they consider it an organ. It's really not a whole lot. There's really not a whole lot to do with gallbladder. It's non-essential tissue, but we'll look at it. The liver, basically digestively, you can't dissolve fats. The liver is so vitally important. It's hard to even. But from a digestive aspect, it makes bile. Bile is made. Remember, fats aren't bonded together. The only way you can get fats are just come together naturally. The hydrophobic, hydrophilic thing. You got to get something in to separate them. Bile salts are what we call an emulsifier that separates them. And it allows part of them to be water soluble so they can be broken down. And then the liver has to process them a lot as well. That's a whole different thing when we get more into the physiology of it. Where the gallbladder is basically, it's the best analogy for the gallbladder is that tank that's got the antifreeze in all of our cars, that overflow tank. We put some in there. What we need, but some of it flows back in, some of it flows back out. We fill it up periodically. It's basically a non-essential storage tank. Does it help to sometimes play a role in compacting or doing some things to the bile itself? Yeah, but often it's for bad because then we end up forming stones, harder areas in there. And like the stomach and like a lot of these other structures, it can expand and contract. And it has little folds in it where those little stones can get stuck, and because they're sharp, they irritate. And that's when gallbladder disease starts. And gallbladder disease is much more common, again, in women than in men. I know it sounds like you guys get all the problems. It's not really true, but gallbladder disease is one of them that's part of it. So yeah, I mean, this is the first thing we're told in emergency room. Hey, if somebody comes in with upper right quadrant plain, and it's a woman, basically you look to see if she has the risk factors associated with it, but you always want to rule out gallbladder disease. What's their diet like? It's pejorative, meaning it's understand these are what we call the 5S. Okay, fair, female, 40, actually it's more like 20 to 40, fertile, childbearing, and the F word we use for people who weigh too much. I don't use that word. Not skinny. Those are the 5Fs. You're skinny as a rail. It's the old joke. If you came in and turned sideways, they mark you absent. Watch out. When my wife, she's wearing like size 2s. My sister still does. Did I show you the picture of my sister? No. Oh, you are in for a treat. This was in August. She's the smaller one. Here you go. Amazed I didn't do that. She weighs the same as she did in college. So does her husband. It can make you sick. I demand a recount. I should be so skinny. No. I would look. Imagine if we were reversed and she was my size and I was her size. You'd laugh. Here we are. 80 years old, October. She was 80 on October 9th. That's me. I'm this one. And so I'm saying it joking like you. She's like, oh, I better just eat half a sandwich. She must be at a size 0. But it's 97. She has 2 boys. Both, one's almost 50, the other one's maybe 53. You kidding me? Still a girl. Thankfully, she's better looking than I am and smarter. Moving on. So the gallbladder is that, and the pancreas is critical. Both the liver and the pancreas, you can't live. You live out of gallbladder. Pancreas never happen. Pancreas is a double duty gland. From a digestive perspective, all of the rest of the digestive enzymes that allow the small intestine to process and subsequently absorb come from the pancreas. By the way, the pancreas also produces insulin and glucagon, endocrine-wise. Pancreas is a very busy gland. Okay, it produces bicarb, which neutralizes the stomach acid. We'll get into that in physiology. The liver. Thankfully, we can live without. We can do now. We know can even do live liver donations. When the transplant city in America is Pittsburgh. Thomas Starzl came here 1980-ish from University of Denver and really changed the world here into the transplant center, pretty much in the United States. And he started, liver transplant was the first one. They had to rely on donors who were deceased. And in order to do that, and unfortunately I knew it very, very well. My dad's brother's, my first cousin, my dad's late brother's oldest child, her husband was age 28. I was in practice. The family was in Pittsburgh. She lived in New Jersey. I got a call in my office up in Oil City. She goes, well, because I knew her husband. I didn't know how far it got. He was on the wait list. They were looking for accommodations in Pittsburgh because he was on the wait list. Whether he had hepatitis, whether he had some birth problem, whether it was a toxin, that he had some terminal liver, he died. Then I got a call later from my uncle saying he had died, before he was called to come to Pittsburgh. He was that close on the list. But that was the early days. I want to tell you that was no later than 1985, I dare say. Right. She was pregnant at the time. She had 2 healthy boys and had a third along the way. Thank God she married a wonderful guy afterwards. Wonderful guy. He was a great dad for those kids. So, largest gland in the body, it predominates. When you open the fetal pig, all you see is the liver that's there. I don't care about this anatomy. These are false ligaments. They're named exactly correct. They are folds of peritoneum that we've come to call ligaments for lack of a better term. And it separates them. Every part of the liver is identical anatomically. We do liver biopsies all the time. Okay? It doesn't matter where you take the piece of liver. One piece of liver looks like the next, looks like the next, looks like the next. There's like some of the fetal umbilical vein happens to be there, laying on there. They call that a ligament. It's round, teres, T-E-R-E-S, means round. So this is what the liver looks like. It's huge. On its undersurface, or inferiorly and behind, posterior, is where the gallbladder is located. So there's not a whole lot to it. They're huge. Okay, and this you could see this area. This is where you basically have the inferior vena cava and the aorta are in and around this particular area, particularly the vena cava that's there. And the entry and exit ways, this is called the porta hepatis. So you have 2 items going in. You have the hepatic artery, which remember came off that trunk that was there, the celiac trunk. It enters, supplying the liver with arterial blood flow. It has the portal vein. All that blood, rich with nutrients and stuff to process or detoxify, enters there. And outflowing, it has a bile duct, because in the meantime it's producing bile. So it's 2 flows going in and 1 flow going out. You'll see how that works momentarily. And again, this layer of mesentery tissue, like an apron lays down, it's called the greater omentum. The lesser omentum, and it really attaches the liver to the stomach. The hepatic artery and vein enter the liver at the porta hepatis. The reality is it's the hepatic. The problem is they should have corrected this. It's the hepatic portal vein. Okay, it leaves the liver. I don't get crazy about this. Okay, the duct that leaves the liver is called the hepatic duct. The offshoot, the overflow, is called the cystic duct. I don't care about that. What I want you to know is when bile finally is making its way down to the small intestine, it's made by the bile duct, the union of those 2 ducts. That's the important. Because the rest of that, if you're going into a field where you have to know that anatomy, they'll tell you. That's like graduate level anatomy. So I don't really get excited about that. But here's what I mean. Here is the porta hepatis. You can see You have a bile, you have the hepatic duct coming out, you have portal vein, you have the hepatic artery. Up here, once the blood has gone through the liver that came by that vein, it's processed, cleansed, if you will, and then it enters by way of the hepatic vein and then joins the inferior vena cava. Remember, I told you we were going to revisit it again. Here you can see that undersurface with actually the bile ducts. That's what we're concerned about. And here's the gallbladder that you saw hanging down from, now we're looking from behind, obviously. Posterior view. These are all identical. They're called lobules, just like a terminology we use in the lung. Small lobes are lobules. So they are, in general, you'll see the micrograph, and you'll see the really good illustration. They are hexagonal, and all they have are hepatocytes, identical liver cells. The liver is very basic. Of all the organs, this is by far and away the most reproductive cells. That's why we can do live liver transplants. Now that we know we're able to do that, we could surgically donate part of a liver. Thankfully, it's that we're able to do that. So the hepatocytes are rich in smooth endoplasmic reticulum because processing fats, detoxifying substances, a lot of the processing is smooth endoplasmic reticulum. They have comparatively a large amount of smooth and a relatively small amount of rough. That's one of the ways we can identify that kind of a cell. And you'll see it comes through because these are those sinusoidal capillaries, great big openings for large stuff to go through. And you'll see where the central vein is, where they're all flowing to. And they each have each point of the hexagon has a triad, a branch of the artery, a branch of the portal vein, and a branch of the bile duct. And so this is what it looks like. For instance, when you have a liver biopsy done to see if you have hepatitis or even on the way to cirrhosis, it would not look like that. Those lobes, anywhere you take it, would become irregular. Scar tissue would start to form. That's how you make the diagnosis. I mean, I only know this because my first wife was exposed, probably because of a transfusion she had in 1981. That was before blood was very safe. In 1987, she probably got exposed to hepatitis C, my guess. It might have come from a blood splatter later. Conceivably, we didn't know about it until the blood splatter. And effectively, fortunately, she was exposed to it. She made antibodies to it. The virus is always in here. But thankfully, she did not develop full-blown active hepatitis C. So she still, because of her health, still has to watch out for it, which is very sad, by the way. We went to an infectious disease specialist who I happen to know, who was he was telling us about, I was describing, as I'm describing to you, what the liver looks like with these kinds of changes. The way they identified is you want to make sure there's no active virus in the bloodstream. So you do, what kind of virus is that? Hepatitis C? Did you get that in micro? You have two choices, DNA or RNA. Nobody wants to offer again? RNA. It's an RNA virus. And so they did an RNA PCR in her bloodstream to determine if you could see the signature of the virus. See? Help me, Lord. So this is what it looks like. There's the central vein. This is the triad. These are the sinusoidal areas, big gaps. So this effectively is really what the capillaries are at. And so they're very leaky. They ooze in from the exterior, okay, and percolate's the perfect word. It just seeps through layers and layers, and when it's doing that, it's being cleansed. There's lots of white blood cells we call stellate macrophages. They get rid of debris. Remember, just like the spleen, this is where you get rid of old red blood cells. That's why you can take over for the spleen if the spleen is removed. This is a great illustration. You can see the size. Here, each one of these is the triad. Hepatic artery to nourish the cells. You can see here very, very clearly the portal vein. And now those materials are flowing to the central vein, flowing away from these little bile canals, canaliculi, if you will. You get into this bile duct, and they flow out. So lots of rough, particularly smooth, lots of functioning going on there, lots of bile processes, stores glucose as glycogen, plasma proteins. We'll get into all that in physiology. Fat soluble vitamins, it's fat. They did so much about BMI, the real tragedy was people. It was one thing when your BMI was up, but when you got that 35, typically around 35% or over, that meant your liver was extraordinarily fat. That's a liver that's on the way to deteriorating, loses function. When your liver stops functioning, you're probably going to die. There aren't a whole lot of livers and transplants and stuff like that. So it does a lot of things. And so effectively what it does to help dissolve fats is it makes bile salts. It's one of the ways we utilize cholesterol appropriately, and it's emulsifier. At the same time, it also was in the bile is the breakdown product called bilirubin, which colors our urine and our feces, the characteristic colors that it has. That is the pigment formed as we excrete heme. Remember, hemoglobin, we can recycle the iron, we can recycle all the globins, but the heme we can't. So that's when you hear about backup, it's called jaundice. It's that bile backing up. It's particularly the heme that's part of it. So, and interestingly, we recycle about 95% of these bile salts that are there. It's called the enterohepatic circulation. I will comment on that when we get to physiology. Right now, it's just enough to know that we recycle a large amount of these. And it shows you the particular passageway. It's there. So, and this is the ideas, viral drugs. I have no idea how. I think I don't recall his first name. What got it? What got him infected? Like that. And then cirrhosis, which is a lot of problems, but obviously it's chronic hepatitis, and most of the time it's from alcohol. Surely the most common cause of it. That's there. And livers are scarce. Livers can regenerate to its full size in 6 to 12 months after 80% removal, which is a remark. We didn't know that at all. You were just constantly, you were waiting for somebody, unfortunately, to die, and liver, assuming that they were an organ donor. I am, but who'd want them? The gallbladder. Not a lot to it. Stores and concentrates the bile. Yeah, great. The honeycomb folds allow it to expand. Good news. And when we talk about a chemical called cholecystokinin, cholecysto is the gallbladder. Kinin squeezes it and pushes the bile out as part of digestion, whether it's there or not. It accelerates digestion. That's there through the small intestine. But unfortunately, it's the stones. The fancy name we give it is calculi, cholesterol, or too few bile salts. It depends. There's a lot of risk factors that are associated. It obstructs, sharp crystals. This is the jaw. Anything that causes that bile to back up results in jaundice. You typically see it most easily in the sclera, the whites of the eyes. But it can be you can see it under fingernails. You can see it inside the mouth. There's a lot of areas that are reflective of that so-called jaundice. Look, one of my patients was awaiting a liver transplant, got one successfully. Lovely guy. I have no idea how he got it. But I mean, when he came in to see, I mean, he was oh my God, hard to believe. And so it's really a sign. The stones you can treat conservatively for the most part. There's a lot of agents, but really lithotripsy is using high. Are you familiar with lithotripsy for either gallstones or for urinary stones? Basically, they immerse you in like a bath, like effectively a big whirlpool tank. And basically they shoot high frequency sound waves at you. And the vibrations deep inside theoretically will break. Litho means stones. Tripsy means to shatter. And that's a very successful treatment. You're sedated in there. They have people supporting you so you don't like fall asleep in the water. Obviously, that would be a bad thing. And there's certainly surgical approaches. One of the big problems, particularly during pregnancy, and this is what happened to my daughter-in-law, with all the, if you're not familiar with IVF, they use a tremendous amount of cholesterol-based hormones like estrogen and progesterone type compounds. Because of that in IVF, it really did a number on her gallbladder. This was her second run of IVF. The first was unsuccessful. Interestingly, she had to take out her gallbladder shortly after she delivered, within less than a week, let's say. And with the third IVF pregnancy, no problem at all. So she had one that was unsuccessful for her to get pregnant, and the other two she was successful. And so that, if you find that interesting, hopefully you do. I'm trying to give you some context about all this stuff. It just shocks me with all those things. My first wife and I couldn't have children biologically. My wife was pregnant. My wife now, with her ex, was pregnant 7 times, had 5 kids, 1 stillborn, 1 miss, 5 live births. Fine. Kids are physically fine. Yet her son, one of her 4 sons, and my son by adoption, both their children came via IVF. Her son, 2 daughters, mine son and daughter. Crazy. So the exocrine function produces pancreatic juice. That's digestive. We'll go over that it's in a precursor form. We'll go over the ducts. That's part of what this is. Okay, they produce these enzymes, they produce water, and they produce bicarbonate to neutralize the acidity from the stomach. The endocrine function we'll talk about in endocrine, that's physiology, insulin, and glucagon. We'll talk about the actions here in physiology as well. So this is typical. The insulin and glucagon area is exterior. In the interior are where you have all of these glands. They have a lot of rough endoplasmic reticulum, much more so than smooth. They're produced, and they're all produced in the inactive form. That's what I talked about with pepsinogen. They're proteolytic enzymes. They'll digest themselves. And I mean, it's nothing worse than pancreatitis. The pain is off the charts when that starts to leak. These are the glandular structures when you hear about someone having pancreatic cancer, which is not a diagnosis you would wish on anybody. It has a very poor, long-term prognosis. So we'll get into all the things that it's alkaline and what's in there, and all these ACEs. You probably will have some of. Did you do all these enzymes yet in biochem? Peptide ACEs. You did. Yeah, we'll get into them more. See, you're excited. I'm sending you all of these. I'm sending you the tests too. Yeah. Who else do I talk to? You're not getting off that easy.
That's okay.
I'm going to give you the link. You're going to have to view in.
Okay.
Or else. You have to do a paper.
Okay.
You're not so think as I dumb I am. Oh no. We're not going to let you. We're getting there. This is the big deal. You saw it here. This is the single most important part of your digestive system. Without it, you can't digest by yourself. That is called the common bile duct. It goes by a new name called the hepatopancreatic ampulla and sphincter, but it's the common bile duct. There's even a lesser one farther along down the lines. This is the big player. This is the duodenum. It's only about 10 inches long. It encircles the head of the pancreas. This is the tail. This is where the bile comes in from the liver, the pancreatic digestive enzymes, bicarbonate, it's water, all come in through here. If that's not there, when I had my surgery, effectively they disconnected it here, rolled it kind of over on itself and sealed it a little bit. Not a lot, sealed it a little bit. It was still, stuff could go in and out of it. And basically took this part of my stomach and sort of attached it down here, past the duodenum, called the jejunostomy. Okay? The most important part that they had to make sure was still functioning was this. When I had to have the surgery effectively done all over again 7 years later. If not, most likely I'm not here talking to you. They would have had to take out the whole. I would have to have been tube fed. And being tube fed, I wasn't going to last the 25 years that I am to here. Well, I wasn't. Now I'm threatening to be here on the 100. They give me tenure. Why should I leave? They'll wheel me in. Same bad jokes. I just won't be able to get up. Yeah. Take my students, please. Jenna will still be here in class. So here they are. And so the hepatopancreatic amp, I don't care about the shape. It has a sphincter that controls the entry. There's even a smaller one. And that's what they kind of show you a little. It's a very good illustration. One of the ones you'll undoubtedly be labeling. I'm going to probably try to get that done, hopefully this weekend. We'll see what's going on. So here you can see it fuses. There's the bile duct, and used to call it the common bile duct, and that's the entry point that's there as they meet together, and it feeds this area. And again, this is the jejunum. It doesn't take long. This is only about 10 inches long. And then this gets into all the secretions. This is the physiology, et cetera, et cetera. Again, I'm saving all those illustrations. So that concludes that, which brings us to the small, and we're almost done with this, by the way. Because the large intestine is relatively easy. We will get that done. Next week, I have the test Monday. I'll pick up with this on Wednesday, and I'll probably get into urinary. I would dare say that, like I said, the lab will be a fun lab. We're going to figure out something with Dr. Buxton and I. Be there. So we'll figure out something exciting with the technology. So because he's run out of ideas for his class. And we already have, and our fetal pigs are in. So based on that, and don't tell anybody else. I'm sure we're not going to have class Friday afternoon of next week. I know your social calendar. Everybody has one. Yeah, work, school, eat, repeat, sleep. Work, school, sleep, repeat. I know that's it. Don't bitch. It happens to all of us. It's good to be busy. Like yesterday, my wife did not feel good. I wasn't comfortable leaving her. Her face was acting up. She's in so much pain. That happens. And it's like, I'm just sitting there watching TV and eating. Just so I don't have anything to do. The eating was fun. Watching old TV shows. Your small intestine, digestion and absorption, this is where it all shakes. About halfway through, this roughly 20 feet, their measurements are all wrong. It's not 2 to 4 meters long. It's approximately 20 feet long. I don't know where they got that. It starts at the ileocecal valve. It starts at the pyloric sphincter, where the stomach joins the duodenum, and continues till it ends at what's called the ileo. That's the last part of it. The ileum, I-L-E-U-M, which is distinguished from the bone, I-L-I-U-M. Cecal, which is the first loop or first segment of the large intestine, the cecum valve. So it's small. It's from the diameter, which is 1 inch to 1.5 inches, as you can see in centimeters. The large is about 2.5 inches in average diameter, which distinguishes it. The small intestine has 3 portions. The shortest and most important, around the head of the pancreas, is the duodenum or duodenum. Okay, jejunum is the next, is sort of in the middle by length. And you can see if you add this up, you got 20 feet. These are more correct measurements. And it's attached by the mesentery. And then the ileum with the E, the longest, by the mesentery as well, and joins the large intestine and the valve. They're almost all identical, the way they look interior, with the exception of where the common bile duct is. When it says has most features, you're going to see the features. It's elegantly designed, as I'm fond of saying, to enhance, it's all about surface area. You got a 20-foot tube that if you split longitudinally and flatten out, that's 1.5 inches wide, that has the absorbance surface area of a tennis court. Bigger than this room. So that's where all these folds, I know I drone on endlessly about folds and this and surface area. This is where it all is. You have a little duodenum, head of the pancreas, in blue and then subsequently in red. And here you can see the juncture point where it terminates, which is the ileocecal valve. And down, when we'll get to it undoubtedly on Wednesday, there's the appendix. There's that illustration you saw before. Rich blood supply, superior, inferior mesenterics, nerve supply, vagus. Okay, this is the structural modifications that provide a tremendous amount of surface area. Ladies and gentlemen, I had an opening into that area, into my, just past my common bile duct, of approximately 1/8 of an inch for my first surgery. 1/8. I could not eat anything. I could not eat anything solid for 6 months. In 2000, in 1993 rather, was at Thanks Friends, invited our families, we merged our families for Thanksgiving dinner. I had water. That's all I could drink was clear liquids, Boosts, waters, all that kind of stuff. That's it. Flow. And I wondered when I was so ill the second time, and they were deciding whether to feed me intravenously, we call TPN or total parenteral nutrition. I can recall to this day, as sick as I was, the gastroenterologist going, let's give him some of that stuff and see what can get through. Because as long as that works, as long as that lining works, that's the best way to absorb stuff. Again, I'm fortunate to be here, and I appreciate that. It has circular folds. They're called plica as a fold, circularis in Latin. It's like they used to have it I've seen it other places, like, arcades and stuff like that. One of those neat things where you put a quarter in and it watches it go all the way around down to the bottom. You know what I'm talking about? These have a science center. That's a plica circularis. Rather than shooting through longitudinally, it wends its way around. So it has all these indentations, so the food is circulating and contacting massive amounts of surface area. Throughout it, it is studded with little finger-like projections called villi, which are about 1 millimeter tall. They are surrounded along all the sides and the top by a layer of simple columnar cells. Those simple columnar cells all have a brush border, which is microvilli. All of that is surface area. Surface area, surface area, surface area. So the circular folds are plica, 1 centimeter deep, chyme slowly spirals, villi, 1 millimeter high. In that, you will find that lymphatic structure we talked about called the lacteal. Lacteal. That's the lymphatic vessel surrounded by a capillary bed in each one of those villi, each one of those fingers. That's the one where it picks up the lymph stuff, the fats, the heavy particles, and sometimes the bad guys that get in there. Okay? The microvilli are the extensions on that cell that give it that fuzzy brush border appearance. That's where the brush border enzymes, when we get to that physiology, that's the final step where we take a disaccharide and make it into a monosaccharide. That's where we take a dipeptide and make it into an amino acid, et cetera, et cetera. It's okay, you're fine. Give you a hard time. All there. So here it is. This is that finger-like goblet cells here. The green is the lacteal, the capillary is about it. Again, you have all that mucosa or gut-associated lymphoid tissue. And then here's the brush border. All those neat that's all surface area, surface area. These are busy cells. They have a lot of mitochondria. There's a lot of processing that goes on. You can always tell from the, sort of that electron microscopic infrastructure a bit about whether the cell's there for processing, if it's an active cell or maybe just a passageway. Here it is again, the enterocytes, because enteric means inside. When we give drugs or medicines parenterally, it means para along the side of the enteric or alimentary canal by injection. They say parenteral medicine will be intravenous, intramuscular, subcutaneous, etc. Here they are. Look at all that, and there's a ton of mucuses you might get. This is a really good view of the brush border. The cells down here. Sometimes it goes through the cell without processing. Sometimes it's processed. We get to that physiology. They are called, where they were called pits. They are called crypts here. Pits in the stomach area. So the intestinal crypts are scattered, not as many as the pits. The enterocytes, the simple columnars, are the big player that are there. The crypts, pardon me for going so fast, they produce the glands that produce the juice, the mucus, etc. that are there. And they also have enteroendocrine cells. When we get to it, the two big players are going to be cholecystokinin, again, gallbladder, they can squeeze it, and secretin, which really, those are the big trigger. Secretin is the big trigger for the pancreas. And there's other cells, defensive cells. We'll get into all of this. These are the most rapidly reproduced cells, really, of the body. Every 2 to 4 days, every single one of them in that roughly 20 feet is replaced. So much processing. And lymphatic tissue and glands that are in there, alkaline mucus, etc., etc. This is the target. Those crypts, fancy name. It's one of those things that you might see on a test going forward in other disciplines. They're called, they always have names. This is called the crypts of Lieberkühn. I think it's Lieberkuhn. Look it up. At CRYPTS, crypts of. Those are where radiation and chemotherapy hammer those so bad. Those cells are so rapidly reproductive, they die. And because you're basically killing, even though it's going to come back, that's why you have diarrhea. That's why you have vomiting. That's why you have terrible abdominal pain. That's really the area. The gastrointestinal is really where people are hit first and consistently. I remember my patient telling me he was getting some kind of treatment, maybe for prostate cancer, long time ago. He said, what else do they do? He said, he told me not to get wipes, but there's a special kind of a wipe with witch hazel, which is sort of a soothing topical agent from years and years ago. He said, because you're going to have so much diarrhea, it's the only thing you're going to be able to use. Imagine that. I mean, you can't avoid it. So thankfully, it's not something you would ever want to go through. And this is all, again, this is where we see segmentation and peristalsis. And we'll look at the physiology of it afterwards, et cetera, et cetera. And again, this is what's neat about this. When food starts to enter there, okay, it basically, when it starts to get in the large intestine, basically it's a stretch receptor says, keep pumping. We want to get this through here. Okay. So, basically this is the one. So rather, when food comes into the stomach, okay, the gastroileal reflex says, if I'm starting to eat something, you better clear out down below. We have more incoming. Basically is what it's saying. If you got to go now because it's coming in. All that good stuff that goes along with it. We'll stop it here with a large intestine. Very little to cover. If I'm really feeling ambitious, I could just send it to you and finish it, which maybe I'll do. All right, we're good. Goodbye. Have fun storming the castle. Have a wonderful weekend. Thank you for coming. I really do appreciate your coming very much.